Error. Electricity in line. Override accepted. Infusion initiated.
Welcome to the INS Infusion Room, the official podcast of the Infusion Nurses Society. In this podcast, we explore all things infusion therapy through a real-life conversation, covering the latest trends, new research, evolving standards, and key industry insights. Whether you're an experienced infusion nurse or new to the field, we aim to keep you informed and empowered with the knowledge to stay at the forefront of the profession. My name's Derek, and I'm your host. Let's dive in. Hello and welcome to another episode of the INS Infusion Room. Today we have Dr. Gilmore in the studio. Welcome, Dr. Gilmore. We're happy to have you.
Thanks for having me.
So in this episode, we're going to talk about the burden of CLABSIs and CRBSIs. So this podcast is 2 of 3 very special podcasts that celebrates you in honor of IV Nurses Day, where here at INS, we are celebrating all week long with free educational events delivered to you each day this week. This episode is sponsored by BD, and we have a very special word from BD. In today's healthcare environment, efficient catheter maintenance isn't just a goal, it's essential. Yet compliance with prevention guidelines remains alarmingly low, reported at just 5%. Current workflows are inefficient, and studies suggest 65% of CLABSIs could be prevented with better practices. Contamination rates are high. Over 50% of post-insertion catheter-related infections stem from inadequate disinfection of hubs and needleless access devices. Introducing PosiFlush, Safe Scrub Pre-Filled Saline Flush Syringes. A streamlined, all-in-one scrub and flush solution designed to simplify line care and improve maintenance practices. In a simulated study of 60 clinicians, Safe Scrub nearly doubled compliance with Scrub the Hub practice compared to standard alcohol pads and saline syringes from 17% to 34%. As Max Holder, nurse manager at Baylor University Medical Center, shares, the all-in-one design is particularly effective in promoting consistent, standardized practices. PosiFlush Safe Scrub has truly supported our efforts to align with best practices in flushing and disinfection. PosiFlush Safe Scrub, because better compliance may mean better outcomes. To learn more about PosiFlush Safe Scrub, visit the website at bd.com/INSPOD. That's bd.com/INSPOD. Before we get started in today's discussion, here's a list of Dr. Gilmore's disclosures. Okay, Dr. Gilmore, again, thanks for coming into the studio today to talk a little bit about CLABSIs and CRBSIs. Do you mind to introduce yourself?
Happy to. Yeah, so I'm Dr. Nate Gilmore. I'm an intensive care physician. I'm also board certified and practiced in the emergency department for a little while too. And I've been heavily involved in my hospital with process improvement and risk management, including CLABSI teams for over a decade now. And I've also been chief of service for our critical care department for 7 years now. So I'm well aware of the complications that come along with critical patients.
Let's jump right in. From your perspective, how significant is the burden of CLABSI and CRBSIs in today's healthcare environment?
You know, I'll be honest, I think it's as significant as ever. The aging population continues to stress our system with older, frail patients getting all the procedures and cancer treatments and just older medical illnesses needing good IV access for their complicated care. And that comes with a certain risk of getting a serious bacterial infection. And how you handle that as a team and as an organization can have a great influence for good and for bad on that risk.
So, what are the downstream effects of these infections on patients, and not just medically, but emotionally and psychologically?
The shortest version is length of stay and money. I mean, and that's every hospital admin and every unit director will know. Oh gosh, this costs us a lot of money, and then they're going to be in the hospital a couple more days at least, and those have clinical impacts that are attached to them. So if you're stuck in the hospital for a couple more days with a serious complication, that increases your risk for another complication. And when you're elderly, delirium is one of the big ones. So you'd hate to have delirium accompany a serious bacterial infection because of a CLABSI or a CRBSI. And that certainly is plausible. I've seen bacteremia cause delirium all by itself. So it weighs on the whole system, and the patient, unfortunately, is the one who suffers the most. And when you think about a bacterial infection, whether it's bacteremia, frank bacteremia, or just presumed CRBSI, that's a very serious complication for usually an elderly, frail patient, and that has some mortality attached to it. So these are very serious implications for the patients, and they have risks for Medicare reimbursement and for like I said, the dollar amount and the length of stay, et cetera. So there's no question that everyone suffers when there's a CRBSI and or CLABSI.
Yeah, speaking of cost, we as healthcare providers, we have an obligation to keep the healthcare costs as low as possible. And part of that is prevention of these infections. Can you elaborate a little bit more on how the infections affect the cost directly?
Absolutely. So um, a lot of reimbursement for healthcare includes fixed amount. So you get a lump sum for your heart surgeries, for example, and has to pay for everything. And if it's one or two cases, it's a little bit of a gamble. But if you're doing hundreds of cases, it becomes an averaged out cost. So if you have a complication that makes them stay in the hospital or in the ICU specifically for another couple of days, that's at least $3,000 to $5,000 per day just to be there, plus all the other treatment care you have to deal with. And then on the back end, they're still in the hospital for another number of days. So it increased the cost just to take care of the patient for those extra days. Plus, sometimes they need major surgeries because the infection includes tissue destruction. I've seen that before. ARDS can come along with a serious bacterial infection, and they're on a ventilator longer. So these complications can be actually more than just a couple days. Worst case, you get a valve infection that needs a valve replacement. I mean, that's a rare complication, but it's very much on there. When you see bacteremia, you should think, oh my gosh, is this going to seed a valve? Is it going to go to the spine? Is it going to have another
Hmm.
complication that's super expensive and deleterious to the patient? And then there's secondary costs. So Medicare and some insurance companies have quality care metrics aggregate that decide how good you are as a system at the care you provide. And they say, hey, are you an A or a B or a C level institution? And how much you get paid is based on that. And so if you keep getting dinged for CRBSIs, they're going to drop you from A to a B or a B to a C, and then they're going to pay you less. And that's well described and well known. Your CFO will absolutely know about that, and your CNO, Chief Nursing Officer, certainly should know about that too, because they're at risk. And if you keep kind of fumbling on these situations, all of your Medicare patients pay you less, and then your reimbursement for the organization gets less. So it's a real, you got
Yeah.
to take care of business or you're going to hurt.
We think of infection prevention as a team sport. So, can you elaborate on how you feel that the infusion nurse plays within this team to prevent or reduce these types of infections?
Yeah, access is the time of risk. so so when you start to use a central access point or even a peripheral line, um, you're potentially opening Pandora's box. And so you're the front end risk exposure for that patient. So following best practice of sterile procedure is absolutely crucial. It's probably the only important thing that we can do. Because I've had patients with central lines for weeks because you can't move them because they're on ECMO and other stuff. And so I know you can have central lines for weeks without CLABSIs, but it means everybody's got to do their part and you got to do it perfectly. And it starts with access and maintenance and keeping the site sterile and dressing changes and all those steps are crucial as well. And some places have a team dedicated to dressing changes and dressing management. I'm not opposed to that. But when it comes to accessing your central position and or your peripheral, if it's depending on where you're at in the building and what you're doing, you're where the bacteria could get in. So following standard procedure is absolutely essential, and paying close attention to make sure that things stay sterile while you're accessing, et cetera.
Have you observed any shifts in CLABSI rates post-COVID? And if so, what are the factors that you feel are driving these changes?
It's interesting. I've actually watched this fairly closely because I'm still on the CLABSI team. So immediately post-COVID, we kept having the same number of CLABSIs, which was like, I thought we were done with this. And that made us look in the mirror and say, well, we can't blame COVID anymore. This is management. This is us. This is the team, as we described. And so we went back to basics and did our hard work and measured our compliance and looked at our dressing changes and made sure everything was done best practice, got that dialed in, and lo and behold, our CLABSI rate dropped again. And nursing turnover is a huge part of this. I don't want to say it's the biggest part, but it might be. And then you include a whole bunch of new nurses that are replacing the experienced ones that are turning over. And those two together, to me, are the reason why you keep having CLABSI issues. So obviously, we were able to nip it in the bud, and we have no CLABSIs now, again, for, I think, over a year. And we still have a lot of turnover, and we still have a lot of new nurses. And it's because our organization has said we've got to keep our eyes on this ball. If we take our eyes off this ball, we'll drop it again, and it's going to hurt everybody. So my advice from having done this for a while and seen it go up and down is you got to keep your eye on that ball and not let attention to CLABSI go away. You can't change your goal from CLABSI to something else. You can add a goal that's different, but don't ever let them take away a goal of zero CLABSI or compliance rates for sterile access and et cetera, et cetera. Because that's how you lose ground, and then you got to start over, and then it takes another 9 months to a year to go back to zero. And so
Yeah. So what do you feel like there are the most common barriers to preventing CLABSIs and CRBSIs?
I think the biggest barrier is lack of understanding, both in terms of how big of a deal it is and how you can actually prevent them. And once people really feel that and understand it like viscerally, then they care. They pay way more attention. And when you pay more attention, you don't screw it up. But when you're kind of nonchalant and you think sterile procedure, but it's no big deal, that's when you get sloppy. But when you're scared because you're like, I don't want this patient to get a CLABSI, or oh my gosh, my unit director is going to break my fingers. Joking, but if everyone in the world is paying super close attention to these CLABSIs, including the CEO and the CNO, and everyone's watching, I'm going to make sure I do my job correctly with sterile procedure and pull the lines that don't need to be there, and et cetera, et cetera. So it's understanding, but also feeling the responsibility of why, hey, this is really important, so don't screw it up.
Yeah. So what do you feel like are the biggest misconceptions or outdated practices that pose challenges in maintaining catheter care standards?
I think, going back to basics again, I think we get rushed, and that's the excuse. It's busy. There's so much going on, and that's all true.
Yep.
But if you don't take a minute to say, oh my gosh, maintaining and accessing this central line, this, highway to the heart is a dangerous thing, and I've got to do it carefully and correctly. That to me is where you run into trouble and needs to be hammered. You just, you need to test your nurses on this. I don't know.
Yeah.
Once a month, once a quarter, at least a couple times a year, to make sure that they know this isn't going away. You need to be able to do sterile procedure operations for your hospital with your eyes closed. And you need to keep a lookout for your colleagues to make sure that the new face on the unit feels that same pressure and knows, hey, this is what we've got to do together. And every hospital's got a little bit different sterile procedure. but they're all similar principles. And so I trust your hospital's sterile procedure generally. Now, if you go back to your institution and say, hey, I want to know what my sterile procedure is, so I want to make sure we do it right, and it's goofy or doesn't make sense or is like
Yeah.
blank, okay,
Yeah.
talk to your CNO and say, hey, we got to work on this. We got to make this better, blah,
Yeah.
blah, blah, blah. But odds are you've got a
Yeah.
protocol that's good. It just needs to be enforced and monitored and reported and made culture, made it, forever in your heart.
Yeah. Agree. We talk about implementation and change in policy all the time here at INS, so I appreciate that statement. So what advancements or best practices have you seen that makes the biggest impact in reducing bloodstream infections?
I think technology has helped us. I think minimizing central lines with good alternatives is a very useful addition. It's not the only solution. You're not going to have a silver bullet that's one thing fixes everything. But when you can not use a central line because you have a better option on somebody that's appropriate for that, so
Yeah.
you can pull the line or you can avoid putting one in the first place. Awesome. Similarly,
And that's
better.
not, and just to clarify, that's not to say that we're replacing the central line,
Correct.
but identifying opportunities to where another line may be most appropriate, right?
100%. I'm off pressures. It's time to pull the line and use something
Yeah.
else. Or,
Yeah.
you know, their blood transfusions are done and their vitals are stable. Yeah, let's get rid of this. Let's pull the central line and use our better peripherals. Or hey, they're a really tough peripheral. I'm gonna get an ultrasound guided, whether it's a midline or just a long dwelling, long peripheral, and use that correctly. I'm not saying you shouldn't use central lines when they're appropriate at all. My point
Right.
is we get
Right.
lazy because hey, we got a good
Right.
access
Right.
point. Like
Well,
why
I
am I
only
gonna
I only bring that up because there's a big misconception around that, and we want to make sure that we're not downgrading our central line just to prevent an infection, but it is a
absolutely right.
bonus whenever we are assessing our patients and identifying the best catheter device for that patient. So
No,
thank you.
you're 100% right. I'm not at all saying you shouldn't use a line when you
Yeah.
need a line.
Yeah.
I'm saying that we get lazy, myself
Yeah.
included. Doctors are like, no, leave it in. You have good access. What are you talking about? Um, as opposed to, hey, we've been off pressors for a day now. Like the vitals are good. Like we got to pull that thing and use
Yeah.
something else. So, and then that includes, I think, sterile, technologies too, sterilizing technologies, and the evidence behind those it's tough to have a really good randomized controlled trial that shows decreasing CLABSIs and blah, 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 but they work. And so if you're struggling with, one portion of the sterile procedure, like, your scrub the hub, technique at your institution is
Yeah.
mediocre at best, there are technologies that'll make it easy and idiot proof. And it's worth it. If you have a CLABSI problem, you've decided that scrub the hub is your problem, it's worth it to use that as opposed to deal with more
Yeah.
CLABSIs.
Yeah.
Um,
Disinfectant caps are really key within that.
Absolutely right. Absolutely right. And, sterile dressings with the right kind of, uh, both hemostatic and antimicrobial technologies, those have been great for us too. We've adopted those very quickly um, and so it's all the above though. I don't want to say it's just one thing. My point is
Yeah.
use technology because it's out there. It can help and pay close attention to technique and maybe use
And,
technology
and
to
it's
help your
not just
technique.
one thing. It's
No,
bundled care, right?
it
Do
is.
you utilize bundles within your organization?
Absolutely. And we call it the sterile bundle.
Yeah, yeah,
and
yeah,
and it
yeah,
it
yeah.
actually includes a package of equipment. So
Oh,
and
that's
that's
great.
another way you can do it. You can have for accessing a central access point, whether it's central line or a port or something, we have an access kit that kind of forces you to use sterile procedure, and hypothetically you should be less likely to screw it up when you do that.
Yeah,
And I know third party companies sell their version of things, and some hospitals just make their own. But that form forcing function, so you have technology that makes you do something a certain way. That's well studied in medicine and in other industries that it makes behavior compliant with what you need. So I love those plans. I love when you have a sterile access point that makes you do the right thing, and if you try to do the wrong thing, you're like blocked.
Yeah.
So that's one
Yeah.
option. And then there's checklists of bundles too to make sure, did you use this a kit, and did you do this, and did you do this, and you got to fill it out and document it. So that's another technique that helps people to do the right thing, is when you know you're going to have to answer a survey, it both teaches you what's on the survey so you know what you're going to be asked. So did I do that? And it also reminds you, hey, if I'm lying about this and they get a CLABSI, I'm going to feel like a real idiot. I hope
Yeah.
that people that feel.
Yeah. So what do you think about the partnerships between nursing, infection preventionists, and industry partners like BD in contributing to progress within infection prevention?
We've been really fortunate to have a relationship with BD that goes back as long as I've been here. And I didn't realize how important it would be until we tried to solve this problem ourselves. And I'm not going to say that you can't. You can solve CLABSI problems yourselves as an institution. The tough part is allocating people from something else to do this. And when BD says, "Hey, we've got people that live this, and they know the science, they know the shortfalls, they know the gaps in care, they know the most common problems. Oh, and by the way, we're going to help you measure your internal compliance. And we have a
Hmm.
teaching program to help you improve your internal compliance. And we'll prove to you that your compliance will go up. And oh, by the way, I've now lived at 2 different cycles where we went up with our CLABSIs and did this thing, and then they go down, which
Yeah.
kills me. But COVID was a huge part of it. We were down until COVID. So we were great until COVID. But then COVID just, blew up the world, and, all of everyone's competencies were shattered, and people were changing jobs left
Yeah.
and right. And
Yeah.
but we got to see it again, where BD comes in and says, "Hey, let's go measure and teach, measure again, and keep doing that cycle." And all of a sudden, it's now doctrine again, and now people are doing it and following it, and it's culture again. So
Yeah.
if we didn't have them to, and honestly, we talked about trying to do it ourselves again, and we're like, "Are you kidding me? No way! Bring them. We'll
Yeah.
hitch ourselves to that wagon, and they'll get on the soapbox, and we'll get on the soapbox with them, and then
Yeah.
teach, measure, measure, measure. Look at
Yeah.
that. Here we are."
Yeah. Absolutely. So when you think about the human side of CLABSI and CRBSI prevention, do you have any stories or patient experiences that you could share?
Man, I got a heartbreaker. I mean, it worked out okay, but a friend of mine who I saw today,
Mhm.
cardiologist, interventional cardiologist, got septic, pneumonia, hypotensive, needed central line. So we placed the line, and he's like my age. So
Oh,
kind of old, but not that old.
I was say you don't
um,
you don't appear that old.
Thank you. Appreciate that. Good answer. And he's relatively right out of training. So he's new and aggressive and knows his stuff, and he's on a little bit of pressure, and then he gets off pressure. He's looking better. So he goes to the floor with the central line in, because this is 10 years ago.
Mhm.
And a new nurse from the floor comes in to give him medicine. And he didn't know her. She didn't seem any different, but he
Yeah.
noticed her hand, you know, operations, sterile procedure with the gloves and the, chloroprep, et cetera, was very less confident and consistent than the previous nurses that were accessing his central line. And within an hour of that medicine, he got rigors and chills
Mm.
and became hypotensive again. And this time was bacteremic with a different pathogen than his pneumonia. So it was a
Oof.
slam dunk, no question CLABSI. And,
Oh,
I hate to throw this one nurse under the bus because she didn't know. She was new. And we didn't do a good enough job at harping on sterile procedure to her on the floor, who
yeah.
sees central lines so rarely, that it happened. And
Yeah.
and so he went back to the ICU. His length of stay was at least 3 or 4 days longer. And this is an interventional EP cardiologist. So imagine if he has permanent disability. Like, you've just taken him off the front lines of taking care of people and giving him pacemakers. So thankfully he recovered 100%, and he's alive and cracking jokes and doing his thing, and he's allowed me to tell his story. And I've told it a number of times. because that one nurse had
Wow.
a catastrophe, but I don't want it to be her problem. I want it to be our problem.
Yeah.
Because if I were to go back to that floor, I wonder how many of those nurses would be just like her.
Yeah.
So collectively,
Absolutely. And
we've got to
we see it in
own.
practice is what
Yeah.
kind of keeps us going. And you know, speaking of keeping us going, sometimes I think it feels like an uphill battle. So what motivates you and your team to continue to fight this battle?
There's the Greek, torture chamber, Greek mythology torture chamber of Sisyphus, who's doomed. His hell is to push a boulder uphill for eternity.
Mm.
And sometimes that's how it feels. Like, I'm gonna
How it
do it
feels
again.
sometimes.
And
Yes.
tomorrow's another day. We're gonna do it again. I will say, for CLABSI especially, when you get to zero, maintaining it at zero is actually more satisfying than getting to zero. Because once you've done it more than once, your dream and goal is culture change, where you have a new breed of team that knows this so well that it's just part of their daily job. And so that's those are the kind of things and people in my meetings, when I say stuff, I'm like, hey guys, I just want to point out, 2 years ago, 18 months ago, we weren't like this. We've changed. We've evolved. We're a new species. So that to me is super satisfying, because I know what it takes to get there. It takes data tracking. It takes a lot of education, a lot of new technologies, and QI for the nurses, and doctors to all the things. But once you get to that steady state, a new steady state of zero or near zero, that's not just pushing the boulder up. I may have to do it again tomorrow, but I'm getting stronger
Yeah.
and better at it.
Yeah.
And we got to come to work. I keep joking, I'm willing to do marketing for them and be on their posters and billboards, but no one takes me up on it. So I got to come and take care of patients. So I got to do something
Yeah.
every day, but at least we can get to zero and stay at zero. And we've been there for over a year now. Again.
Well, congratulations. That is a huge feat. So kudos to you and your team. For clinicians listening today, what's one action that they can take tomorrow to reduce infection risk and protect their patients?
I think sterile procedure. I hate to sound like a broken record, but you've got to know your institution's sterile procedure and know how compliant you are as a team are with it individually, and the rest of you guys. And if you're, not necessarily in management, but just a frontliner, I'm sure there's a committee on this. Join it and say, I want to be part of this winning team of getting to zero. And then in that, you're going to eat, breathe, and eat, drink, and breathe the protocols, and they may need to be changed. There may be something really missing there that you're gonna have to nerd out about and read and say, oh my gosh, this key thing is missing. Or you say, we just suck at implementing. We just, like we did, we were like, man, our compliance is below 40%. How about that? And lo and behold, we get compliance above 90, and CLABSIs just go away. So to me, that's the, first step is to join the team, and you can do that psychologically. You don't have to be part of a team, but you can say, hey, I want to know what our prevention
Yeah.
protocol is. And then if it's missing something, you can volunteer yourself to your unit director or your, vice president of nursing, whoever in charge of this, and say, I want to make this better. And
Yeah.
oh, by the way,
Get
here's where
involved.
I think we need to. Most institutions will put their arm around you and say, welcome aboard. Thank you.
Yeah.
Um,
Yeah.
and for physicians that might be listening to this or part of this, or NPs or PAs, you need to join the fray as well. Because
Mhm.
when we're all saying the same thing, something needs to be changed. We're all saying this needs to be changed. That's when it changes. But if you only have a couple people saying it, well, I don't know, we really have to do this. But if everyone, the doctors, the
Yeah.
nurses, the nursing leaders, that's when you get movement. And oh, by the way, it's
Mhm.
your patient. So you should care how many of your patients are getting CLABSIs and CRBSIs, and know how you can help them go away for good, because that's healthcare. And if we don't think and manage healthcare associated risks, then we're lying to ourselves, and that's unfortunate. And I think most
Yeah.
clinicians don't know
Yeah.
how serious it can be, and or how often it happens, or how to prevent it. So first step is to pay attention and care, and then second is to go find out, well, what are the drivers and how are we performing and what do we need to do better. So it obviously I have lived this for a while and I love it, especially because it's not very often you get to win a video game twice.
That's right. That's right. So flipping the question around, how can our organization support our clinicians in this initiative?
Generally, there's a cohort of nursing specialists, and sometimes they live as infection preventionists, sometimes they're infusion specialists, sometimes they're just unit directors, sometimes they're the lead nurse on the floor that day who gives breaks but pays close attention to that kind of stuff. So there's different ways that cat can be skinned. The bottom line is the most experienced and knowledgeable in that area needs to be given the opportunity to help facilitate growth. And I would argue probably through uh, a multitude of ways, which includes education programs. It includes if you can develop a testing modality where you sample and measure, that's the ideal. Because then if you measure and report back the performance, then everybody's going to start caring because they don't want to be seen as the weak link. But all the above, and so you're basically a team leader because you're most experienced and most passionate and most knowledgeable about this specific area, and that includes in the moment. So if you see something, say something. If you see somebody doing something, hey, whoa, go wash your hands again, or hey, that's contaminated. So speak up immediately, because that will actually have more of an impact on the people in the room than anything else you do. So speak up is first and foremost. But in the meantime, also join these teams and help participate the teams and lead from a bureaucratic organizational level too.
Well, thank you. And for the final question today, looking ahead, what gives you hope about the future of vascular access safety and infection prevention?
So I've spent all this time talking about human behavior.
Yeah.
And I know that's the key. Okay. And technology. I think technology is going to help us slay the dragon for good. I think technology continues with more and more innovation and cooler, newer, better things. And once again, forcing function. So when you have technology that makes you use your hands a certain way, that's another way. So I think, I'm not saying that we can't do it without it, because we are. My hospital's doing it right now, and it's been over a year. But I do think technology will help us hardwire and permanently, take this off the table, because it'll be quote unquote impossible or almost impossible to introduce microbes during this process. But we're not there yet. So my pipe dream is what I kind of think about and ponder. I wonder about this. I wonder, what about if you did this? I nerd out about that. Not everybody's going to do that, and that's okay. So in the meantime, you got to, hit your bunny shots and make sure you don't ignore the mandatory steps to sterile procedure that will keep you safe, as it's kept my patients safe for over a year.
I want to thank you again for coming on for today's episode. It's been a pleasure. I know that you're a busy guy, so we really appreciate the time you spent with us today.
Pleasure's mine. And thanks for all the work you do, and keep it up. And everyone listening, keep it up, keep your chin up. I promise you can get there. Just, you got to go get your friends and get a team and work together and decide it's a goal that everyone's going to do, because together everyone can do it. And I know, because my hospital, bunch of CLABSIs dropped them down, bunch of CLABSIs dropped them down, and now we're staying down. So if we can do it, you can do it.
And with that, as always, I'm your host, Derek, and it's been a pleasure sharing this important discussion with you. Remember, knowledge empowers us to make informed decisions. Until next time, stay informed, stay curious, and keep gaining knowledge.
Infusion complete.